The patient is placed supine on a postless table in a few degrees of Trendelenburg with both feet secured in well-padded boots. The patient is prepped and draped, and the C-arm enters between the patient's legs. A spinal needle is inserted onto the femoral neck, and 10 to 15 cc's of air is injected in order to disrupt the suction seal of the labrum. Fluoroscopy is used to confirm that an air arthrogram has been performed. Traction is pulled, and fluoroscopy is used to confirm adequate distraction of the hip joint. The ioband draped is removed in the region where anterolateral and mid-anterior portals will be made in order to avoid ioband entering the joint. Another spinal needle is placed on top of the patient's body in the expected trajectory of entry through the AL portal. Fluoroscopy is used to confirm appropriate trajectory, and a skin marker is used to mark the trajectory on the patient's skin. The spinal needle is then inserted in the skin just anterior to the greater trochanter, in line with the marked trajectory, aiming parallel to the floor or slightly posteriorly. The bevel of the needle should be pointing distally. Once the surgeon feels resistance of the needle tip against the joint capsule, fluoroscopy should be used to confirm appropriate position of the needle. Once the surgeon is satisfied with needle positioning on AP fluoroscopy, the C-arm is rotated under the drape for lateral fluoroscopy. This image should demonstrate the spinal needle running approximately down the midline to slightly anterior side of the femoral neck. Once a satisfactory lateral image is obtained, the C-arm is brought back to an AP position to confirm that the proximal distal trajectory is still appropriate. At this point, the spinal needle is advanced just enough to pierce the joint capsule. The inner needle is removed and a nitinol wire is inserted into the outer needle until there is resistance. Another fluoroscopy image is obtained, which should demonstrate the nitinol wire entering and stopping in the acetabular fossa. Once the nitinol wire is identified in the correct position, a skin marker can be used to mark the location of the MAP. This portal location should be marked a total of 7 centimeters away from and about 2 centimeters distal to the AL portal. A transverse skin incision can be made immediately adjacent to the spinal needle, such that the needle is now in the AL portal incision. The spinal needle is then removed while making sure to keep the nitinol wire in the joint. A cannulated switching stick is advanced over the wire. The arthroscopy obturator is then advanced over the switching stick. The cannulated switching stick and nitinol wire are then removed, and a 30-degree arthroscope is advanced into the obturator. The surgeon should then identify the triangle formed by the femoral head, acetabulum/labrum, and anterior joint capsule. A spinal needle is then inserted at the previously marked location for the MAP. The surgeon should attempt to triangulate the arthroscope and spinal needle such that the needle enters the triangle at approximately the 12 o'clock position. Once the spinal needle enters the joint in the appropriate location, the same steps as mentioned previously are repeated to complete the portal. A 5.5 millimeter slotted cannula is inserted into the MAP. Fluid inflow is turned on, and the surgeon can commence central compartment work.